What goes into deciding if a time-limited therapy or continuous duration therapy is best for a CLL patient?
So this is probably the hottest question in CLL today because it's so relevant. And there are a few features on and today, as of today, because things may change next month, is that you either start therapy with a BTK inhibitor and that is expected to be continued indefinite therapy, or a regimen when you combine venetoclax with an antibody called obinutuzumab, and that combination is given for a period of 12 months. For the first 6 months, you get both agents. For the other 6 months, you get just venetoclax. So that's time-limited therapy. You get that for 12 months. So in the majority of times, patients will be eligible for both. There are certain features that might guide you more towards one or the other, but the reality is that most patients can really be considered for both. There are certain features. We talked before about the immunoglobulin gene heavy gene rearrangement. So IgHV mutations or unmutated status can define a little bit if one agent is better than the other. The TP53 mutation, the deletion 17p, maybe there's also a difference between one and the other. But it's not that venetoclax is not really active in this group of patients. So what I do with patients when we are discussing therapy, the time has come, patient needs treatment, and we have those options, we try to put everything in perspective. Because when you're combining the venetoclax with obinutuzumab, the patient has to come to the office to get the infusion. So transportation might be an issue, or distance to the center might be an issue. Patients may have drop in blood counts, so may need more frequent labs. Are they going to get the labs? Are they able to get the labs more frequently? So that can be a problem. So it's the bigger dedication to the therapy in the beginning, so a little bit more greater effort, with the idea that over time this effort will decrease. Usually the therapy gets easier after the first few cycles, less frequent visits, not as much infusions, less frequent labs, and then after the 6 months is just a pill. So you pay your price in the beginning, and you have the chance of just getting 12 months of therapy and stopping. Versus the BTK inhibitor, which is easier to start, also has a different pattern of side effects that some patients might not be the best ones. Some cardiovascular problems. It's not that it's absolute no-no, but sometimes we'll have to take that with a little more caution. But it tends to be an easier thing. You start your pill and you take your pill, but you take your pill forever. So when I'm discussing, I will take into consideration these genetic features that may guide us. One agent may be better than the other because of genetic features, patient preference, what they are willing to do, what they want, and also these social issues. They may also help us on the proximity to center, distance, and frequency, and where they are in their life. So when we're discussing this, I say that CLL is a lion trying to attack you. We either put a lion in a cage, which is a BTK inhibitor. As long as you take the BTK inhibitor, the majority of times the lion is there. The lion is awake because we don't really have much deep responses with BTK inhibitors by themselves. So the lion is alive, but inside a cage. You stop the pill, you open the cage, the lion is out. With venetoclax combinations, you have deeper responses. So you put the lion to sleep. So you dart, you put him to sleep, there's no cage, the lion's there, sleeping, and you can probably walk around for a while and the lion will be there sleeping. Eventually the lion will wake up, and then when he wakes up, you decide what to do. So it's a different approach to take care of the lion that's trying to attack you. But it's not that straightforward. You need this, you need that. It's really defining which patient fits each treatment best.